This is John Geaver from MedPage Today with Dr. Albert Wang of the University of Chicago Medical Center, who is speaking with me by remote video. Dr. Wang has led a study that projects the burden of diabetes in the United States for the next 25 years, and I understand that the numbers are pretty scary. Dr. Wang, why don't you tell us what it was you did and what it was you found?
Well, we all know that diabetes is already at epidemic levels with nearly 24 million people with the disease already in 2009. And we know that they're a very expensive group of patients to take care of. So we were commissioned by the National Changing Diabetes Program to forecast what will happen to that population in the next 25 years. This is an exercise that has been done about every 3 or 4 years. And we thought it was worth repeating in light of the current healthcare crisis that we face in terms of rising healthcare costs. So we developed a fairly innovative diabetes cost population model that tracks the size of the population over the next 25 years, accounting for things like rates of obesity, overweight, as well as the natural history of diabetes. And we tracked what would happen to the population and how much they would cost over 25 years. And what we found was that we were expecting the population to double in size in the next 25 years, going from 24 million to 44 million, and we're expecting their direct medical costs to triple over that same period of time. And we find very similar and actually potentially worse projections for the Medicare population, the group of people that have end-stage renal disease, or the elderly, people over 65 that are enrolled in Medicare. So these projections are very worrisome, and it's actually also interesting to note the history of these projections over the last 2 decades. Projections have almost always forecasted a significant increase in the size of the population, but what's sort of humbling is that the projections have always been wrong. In fact, the projections have always shown that have expected lower numbers of diabetes patients. So, for example, one projection expected that 20 million people would have diabetes by 2050, and we are already at 24 million. These numbers are very scary. And one of the natural questions that people will ask about them is, what should we do to try to change either the number of people that have the disease or at least bend these cost curves downwards? These are questions that the entire country is facing right now in terms of healthcare costs. In the case of diabetes, we have at least 2 main things that we know that we can do to try to change the curve. One is to prevent the onset of diabetes to begin with. And fortunately, just over the last few years, we now have new trial data that shows that we can really prevent diabetes through diet and exercise. In fact, we know from the Diabetes Prevention Program that diet and exercise is a more effective way of preventing diabetes than medications. So nearly over 50% of, we know that we can reduce the incidence of diabetes by over 50% with modest weight loss through diet and exercise, about 30 minutes a day for most days of the week. And this is in groups of people with pre-diabetes. And then the second major way in which we believe we can bend the cost curve, although it's more complicated, is through better diabetes care. And so if we can get more young patients in particular to treatment goals for glucose, blood pressure, and cholesterol very early on in their disease, we believe that we can prevent many of the complications of diabetes over 20 to 30 years. And there are already there are many public health interventions already underway to try to do both of those things right now.
And to go back to the results for a minute, could you explain how it is that the costs seem to go up so much faster than the number of people with diabetes?
Right. That has to do with the fact that we've accounted for the natural history of diabetes in our model. Most prior cost projections, if there are any, simply multiply an average cost for a diabetes patient to the number of people that have diabetes. But what we have done is we are expecting basically a large number of people to have prolonged duration of diabetes 25 years from now, more so than now. And prolonged duration of diabetes is linked to diabetes complications. So the reason that costs rise is that we're expecting many people to have diabetes complications 25 years from now.
And is this because of longer longevity, people living longer with diabetes, or is this also taking account of younger onset? People are now fatter and younger, or fatter at younger ages than they used to be.
It's a little bit of both. So we're expecting, we are doing such a good job of keeping people alive, preventing cardiovascular disease. The ironic thing is that they actually end up living longer, and living longer is associated with more microvascular complications like blindness, end-stage renal disease, and amputation. So diabetes patients are living longer, and they are, and so they are at greater risk for some complications because of that.
And did you do any formal sensitivity analyses of the effects of interventions to reduce the burden over time?
We have done a prior analysis that was described in a health affairs paper in September that described what would happen if we rolled out a federal program designed to improve the delivery of diabetes care. So this is not about diabetes prevention, but just improved delivery of diabetes care. And we found that in some cases, what we can do is keep costs neutral, but improve the delivery of care and prevent some complications, especially in middle-aged and older patients. We actually found that in certain young groups of patients, so people in their 20s and early 30s, we could actually reduce overall spending over a 20-year time frame. So we've done that analysis. We have not looked at ways of shifting, for example, the distribution of weight categories, which would obviously be of interest to many people.
And what about surgical interventions, endoscopic interventions like bariatric surgery, various types? We've seen some very dramatic effects on diabetes in people who are overweight and obese.
Well, there's no question that the data from bariatric surgery is very dramatic, and many people would tell you that bariatric surgery has the most dramatic effect on reducing or transforming people's diabetes. In fact, in some cases, eliminating it even days after surgery without any weight loss. So there is something complicated going on with bariatric surgery. I think that the great challenge with bariatric surgery is delivering it to on a public health level, something very expensive, costly, and with the limited number of surgeons that we have in the country. So I think that there are some realistic limitations to thinking about bariatric surgery as a public health weapon against diabetes. Although I know that there's some people certainly thinking about that, and our model could certainly be used to forecast what would happen if we were to implement such a program.
All right, well, I think that pretty much does it for us. Dr. Wang, thank you very much. I'm John Giever, MedPage Today.